My name is Ashley, and today I am very excited to introduce that my surgeon, Dr. Jeffrey Verlotta from Kaiser Oakland, is joining us on the podcast. Welcome to the One Lung Lounge. Today, we are going to talk all about lung removals and why it's a growing option for some of us with a stage 4 lung cancer diagnosis. Dr. Verlotta has made such an impact in my life personally. He is my surgeon, so he performed a pneumonectomy on me almost 2 years ago. And he has been very involved in my care on moving onward, providing insight, support, and his medical opinion on my treatment path. So I'm going to turn it over to Dr. Bellotta to introduce himself, and then we're going to dive in. Welcome.
Yeah, thank you, Ashley. It's great to be on. I'm really excited to be on. And yes, so I'm Dr. Jeff Vallata, and I am a thoracic surgeon here at Kaiser and based out of Oakland. And just like Ashley said, we met over 2 years ago, and I think that's that's the amazing thing. It's about for me, it's not what I do or what titles and everything. It's just really about the unique patient interactions because not every patient is the same. Every patient is different with lung cancer, including stage 4. And regardless of biomarkers, regardless of all that stuff. And I think that's why it's so crucial that and so happy to be on that, Ashley kind of shares her story throughout everything, but also to help other people understand what stage 4 is all about.
I tell people this all the time. You're one of the few doctors I feel like views me as more than just a staging. Yeah.
Yeah, absolutely. And I've just, we've known each other for so long and through everything. And I think that's the cool thing. The way I look at, to be honest, the way I look at you is that you're um obviously young and vibrant, but the main thing being, yes, young, vibrant, young woman with a family, friends, a lot of people that care for her, a lot of life to live. And so it's more about that then yes, I do consider, yes, I do know you have lung cancer, but not regardless of stage, I think we have to do in our power as clinicians everything we can for you, regardless of how good or bad or little or terrible your disease is for anybody, that we do everything we can to think outside of the box,
Mhm.
innovative, maybe even above standard, super standard of care, because I can't wait, like you can't wait for the clinical trials to come through. And again, even those clinical trials can be potentially cherry picked as well as the perfect patient, and everybody's going to be different. So I think that's the way I kind of look at it is like you have the right to live forever too, regardless of,
Yeah.
your lung cancer diagnosis.
Yeah, it hurts when I'm attempting to talk with the doctor and they refuse to talk with me after they see stage 4. They won't even like look at my charts. I mean, not now, but when I was pursuing surgery, many surgeons wouldn't even, they refuse to talk to me. It's, yeah.
No, it's crazy. And that's the thing. And that's why you went through so many different opinions, which is, I know what you always recommend, but it's key because it's not like we came into contact, and through happenstance, through random after, I think, multiple different opinions. So it wasn't like on opinion number one or two or three. And again, it wasn't even directly you to me. It was directly through somebody that I had trained in fellowship with in Boston
Hmm.
that had said, "Oh yeah, I know a guy out there that may be open to, thinking outside the box type thing." But again, it was totally right.
So
It's
random.
random,
Yeah.
completely.
Yeah. So we have so much to talk about. So I'm hoping you can give us a brief history lesson on the treatment options for stage 4 leading up to when lung removals were being considered. So, like, historically, what are the options for someone with lung cancer or stage 4 lung cancer?
So historically, it's always been about chemotherapy.
Okay.
Chemotherapy has been the mainstay historically,
Mhm.
from decades ago, right? For any cancer, but specifically stage 4 lung cancer was always just about your classic chemotherapy. And it was usually two types that are still used now that have been the most kind of shown to be the most effective. That's how everything was based off these two types of chemotherapy. And that's always what it's kind of been. And then if that didn't work, you would go to a second line chemotherapy. If that didn't work, a third line chemotherapy, right? But then
Mhm.
over the last 10 to 20 years, we started to get targeted therapy, meaning the whole biomarker scene where if you had a targetable mutation in your cancer, stage 4, that maybe you could take a pill, or for immunotherapy, have an infusion that had your immune cells overreact and try to attack the cancer itself. So it's, and then now what we're in is this, in this combination of chemotherapy, either immunotherapy and or targeted therapy,
Yeah.
right? And then now a little bit more explosion of maybe CAR T cell trials, maybe vaccines, antibody drug conjugates, clinical
Mhm.
trials, all that related. But that's kind of what I would say from old to new therapy. But
Mhm.
I purposely did not say anything about surgery in that realm, because this is, and I'm sure you'll ask that, or what we're going to get into, but that is generally still, even today, whatever it is, April 22nd, 2025, after Easter, it is not in the armamentarium I've even thought about
Mhm.
at the majority, I'd say 99% of the country, and then 1% maybe, but even then, are they true believers
Mhm.
in it? I would say even less. So,
Yeah. Yeah. So I'm
unfortunately,
hearing chemo, targeted treatment, and immunotherapy. And historically speaking, for stage 4, so very limited options. And then you have CAR T and like all the stuff in trials right now. Like I'm going on an antibody drug conjugate. There's CAR T. There's vaccines.
yeah.
Um, so historically, why have surgeons been unwilling to perform surgery on someone with stage 4?
Yeah, that's that's the age-old question. The age-old question, and again, I don't have all the scientific answers for it, because really it's more based off of the data that was all older data with, in looking at stage 4, where classically stage 4, most people did not live past 6 months,
Yeah.
or even 9 months or 12 months.
Hmm.
And so the idea is that surgery, just the recovery alone back then, especially since it was open surgery a lot, or in all that you wouldn't, patients didn't live long enough to even be thinking about surgery. That was kind of the old school way of thinking, right? But then now, right, you have newer drugs and immunotherapy and targeted biomarkers and all that stuff. So patients with stage 4 are living longer.
Yeah.
So now it's in the realm of things is like, well, what if you could do surgery? But the reason why most people with stage 4, or surgeons or whatnot, or medical oncologists, or whoever you want to talk about, is that because very rarely in stage 4 do you see it maybe in well controlled, or just in certain locations. And so that's when you get into the whole thing. Well, if it's in multiple spots, bone, brain, but different spots of the bone, left side, right side, lung, right? The idea is surgery is always by surgeons, always considered local treatment. So
Hmm.
wherever something is local, we chop it out and that's it. But if we only, the thinking that a lot of us surgeons have had, and still think to an extent, is that if you just chop out something locally, we can't as surgeons control the other side of the lung, or the bone, or the brain. But I would say newer thinking, in my way of thinking personally, is that yes, I know that. And I know that I'm only, chopping out one different area, right?
Hmm.
But if that other area is controlled in the bone brains, with whether it's a combination of radiation, or they had surgery in that other area, or more commonly, they're stable and doing well on immunotherapy, chemotherapy, or targeted therapy, then I think the armamentarium for stage 4 should be, it's not that surgery alone is what's going to do it, but it's a combination of all the different systemic therapy options that you still will need for stage 4, because technically stage 4 is spread, right? So
Yeah.
you're going to need some of those forms of medical treatment. But all I'm saying is we should maybe be thinking about, and every patient's different, so it's a case by case
Yeah.
basis, but maybe we should be thinking about just adding surgery into that armamentarium, right?
Hmm.
That's like
Hmm.
we do for stage 1,
Yeah.
2, and 3 now, right? So why does it have to be that much different for stage 4 as well?
Hmm.
Because we have better drugs now and patients live a lot longer.
So when is data going to be updated? Because I always tell people data does not represent young people. I don't know about the smoking history, but like many young women are being diagnosed with lung cancer. So is it going to be a decade, 2 decades from now? Like when does data actually update?
Great question. So The answer to that is probably not 2 decades, but
Mhm.
we're at least another to have really good data. We're at least another several years away.
Mm.
So in the meantime, that's anywhere from 3 to 5 years away, right? There's great clinical trials going on at MD Anderson, but again, it's only a select, select patients, and may not be representative of everybody. But when you have stage 4 lung cancer, even if you have a good kind of prognostic stage 4 lung cancer or whatnot, 2, 3, 4, 5 years, that's too long to wait
A lot could
for some
change.
data.
A lot could
So
change in 6 months. Like
a
that's
lot
a
could change,
long,
right,
long
in six
time.
months or even less, as
Yeah.
you and I know, just like, or just how you may feel, not necessarily cancer growing, but how you may feel. And so to me, I think what we need to do is we need to extrapolate from some of these kind of real world retrospective studies. And a lot of surgeons, especially at some of these kind of high ranking places, which it's nothing against that. It's just that they want this level 1 evidence or this, and in stage 4 disease, patients don't have time to wait for that, right?
I'm
Family
I'm
members don't
sorry,
have
what do
time
you
to wait
mean
for.
level one evidence? Is that what you said?
Oh,
I'm not
randomized
sure.
controlled trials, right? Randomized controlled trial data.
Oh, okay.
So what I mean by that is, having the randomized controlled trial data that shows an overall survival benefit or disease-free survival benefit. We don't have time for that or wait for that. So some of us will extrapolate what we see retrospectively, because there is data in other small little retrospective, especially data out of Asia, where you see that a lot with stage 4 Asian women, a lot more so, and a different kind of biology in what we may see here in the United States. But there is some data retrospectively to look that patients did live longer and did improve survival with the combination of surgery versus the ones that only got the classic systemic therapy or biomarker therapy or targeted therapy. So there is some of that data. So I personally started kind of looking back at that, because it just coincides with a lot of the research that I do for screening, and just looking at a lot of the Asian women that we see here, because we see so much stage 4, in our Asian, or a lot of Asian women in patients with Asian, or any type, but usually in women in general.
Hmm.
That why not extrapolate and that say, as long as the patient, you or whoever as the patient understands, hey, I don't have randomized controlled trial data. A lot of people are not going to necessarily offer this, but hey, I don't know if we don't have any other great options. I think, based on what I've seen in other kind of in the past, and now I can say in my experience now in the past, that I think you could live longer if we do this. I can't guarantee it. And yes, you may have a complication after surgery, but these are the risks. And if you and I both understand that, you, me, the family understand that, and I think that's totally how we have to continue on that path. And that's kind of where we're at right now, which is exactly where I was at 5 years ago doing this, but nothing has really changed, except you may not get so many naysayers right now than what I would have got 5 years ago.
Um, excuse me. Is there any research or data that you know offhand, like coming out of China or like here in the States, that can be recommended to people exploring surgery?
Yeah, I think the best data to look at, and it was just recently published, is at the Annals of Thoracic Surgery. Dr. Antonoff and colleagues, whether through the Society of Thoracic Surgeons, came out with the evidence-based document of recommendations by experts in the field of thoracic surgery for specifically looking at surgery for stage 4. Again, it's online right now. It's out of the Annals of Thoracic Surgery. It was just recently published within the last 8 months or so. That gives you kind of a consensus of, they look at all the data, and most of them they're all older, retrospective, or past studies, but they combine all that and then they come up as a group and they vote for kind of what they would think on these certain statements of surgery may be beneficial for this, surgery may be beneficial for this case in all stage 4. And if you actually look at that document, they did come to a somewhat consensus of saying, in these select certain patients, and you have to read there's nuances to it, but that surgery may be beneficial. Again, not saying it is that beneficial and it is the standard of care. It's just saying that it may be offered and it may be okay to undergo surgery for stage 4. That what I would say is the most up to date kind of best consensus looking of what we think of from experts, and looking at all of the data that is available. That
Mhm.
consensus document should be in everybody with stage 4 their email, or their back pocket, because it does show the recommendations that it can be offered, it is possible, it is
Mhm.
not routinely not like it's not all just negative in that. In fact, there is some, there is some consensus saying that yes, surgery could be reasonable in this patient setting.
Mhm.
And then so you take that to your cancer doctor, your medical oncologist,
Yeah.
radiation oncologist, your surgeon, and then you show that.
Mhm.
And that I think is the strongest quote unquote evidence that we have.
Can you say it one more time a bit slower?
Yeah, so it's the Annals of Thoracic Surgery, the Society of Thoracic Surgeons
Okay.
consensus statement, where a bunch of expert surgeons from our main big society comes together and looks at all the data that's out there right now in the literature and beyond, and looks and then compiles the data, looks at the results, and then votes on it. And they have a consensus of whether or not the majority of them are in consensus or not. And if they
Mhm.
are in consensus for that, which a lot of these statements, they are in consensus of pro surgery potentially as being an option for stage 4,
Mhm.
that will help, I
Yeah.
think, explain things better.
Yeah, and we can get down the line. We'll talk a little bit about how someone can advocate for surgery if that's what they're considering. Um, I want to back up a bit and you're one of the few surgeons that are performing full lung removals, pneumonectomies on stage 4 lung cancer patients. So, can you talk a little bit about how you got into this? And I don't know, like, if you, like, how many patients have you performed the surgery on, and do you have any data on that?
Yes. So to answer a couple of questions, that is actively something that I'm looking at, even if we talked about this, because essentially looking back at it, the whole question is it's a mix of like, was it a lobectomy, a bilobectomy,
Mhm.
a sleeve resection, or pneumonectomy for stage 4? So I am currently looking at that to see actually how out of how many per se, like similar to you, were actually pneumonectomies, complete removal. Obviously, that's going to be less than, say, a lobectomy,
Mhm.
which is the more common for stage 4.
Mhm.
But again, the pneumonectomy and taking out the whole lung and or the pleura
Mhm.
is a more thing that just nobody has any data on it. So if
Mhm.
anything, that's why I'm looking into that. So yes, to answer
Yeah.
your question, no, I don't know the exact number, but I'm still looking at that, pulling all my cases from 2014 on to see how many. I know there's a handful, but I just can't tell you completely exactly how many and whatnot. So that's an important question. The second thing to back up is that yes, you're right. It is not common. In fact, we shouldn't. This is going to, this is what we have to be careful with our audience is that yes, normally the surgeons would say if it's for stage 4, pneumonectomy is a no-go.
Mhm.
And then even a no-go if it's earlier stage 2. Most surgeons now are now advocating for trying to downstage things to shrink it down so you can get away with like a sleeve resection or a
Oh,
lobectomy or a bilobectomy, even for
for stage 1 too?
yeah, yes.
Interesting.
So that's where a lot of the data, everything the data is leaning towards less is better. Trying to do less lung sparing, we call it, save more lung. That was
Hmm.
very opposite than 20, 30 years ago, where
Yeah.
for stage 1, we used to just cut it all out. And before my time, but then uh, there was a lot of complications from that. So patients were getting surgery, getting the cancer out, but then they were dying from their pneumonectomy
Yeah.
or whatnot. And so now a lot of surgeons are trying to go shy away from that. And so it's not that I think that they're wrong. I think that's appropriate. But all I'm trying to say now and advocate for is if for some reason your case does require potentially a pneumonectomy
Hmm.
to potentially improve your survival.
Hmm.
And the risks are, the benefits outweigh the risk depending on your surgeon and your case to not just rule it out because it's going to be a pneumonectomy. That's the problem that I have is
Hmm.
that most surgeons, if you say, oh, it's going to be a pneumonectomy, they will not even, regardless of what the case is, stage 1, 2, 3, or 4, they're like done with it. Like, oh, the complication rate's too high. Well, in reality, most of the complication rates that are high are based off of older data. And again, it's not like it's 90% that you're going to die after surgery. It's
Yeah.
25% in a lot of the data that you're going to have a major complication or a bronchopleural fistula, which is leaking from the airway because you've had chemo and radiation, or you may die and have a lot of complications. But again, we're not talking 90% major complication. We're talking 20 to 40%. And if
Hmm.
you're a patient that absolutely could get better if you remove all that disease, and willing to take that risk, meaning the overall majority that you could do well, you should at least just discuss that with your surgeon. The
Yeah.
problem that I have right now is there's too many, everybody's just saying, no, that's the data from, that's the data that we quote. That risk is too high. We won't even think about it. Or the other thing is, besides the risk, the surgeon and the oncologist will say, well, you have stage 4 disease. The cat's out of the bag.
Yeah.
It's just gonna spread somewhere else right afterwards. Well,
Hmm.
how do you know that in every person?
Yeah.
It wasn't like that for you,
Hmm.
right?
Yeah.
But that's what everybody thought.
Hmm.
So, and right now we don't have enough genetic therapy or good blood tests, still biomarker tests, liquid biopsy tests to still know, is it going to be you that's going to live longer after surgery, or is it going to be you're going to like metastasize 1 month after surgery? We don't know that. We
Yeah.
still can't predict that. And
Yeah.
until we predict that, I will continue to do what I'm doing, which is on a case by case basis, be open to potential if we have to take out the whole lung. By no means is it something that we take lightly and that we do it for everybody, but
Yeah.
in certain cases, especially like in your case and in a few others, it can be beneficial and you can live longer, despite not having uh, one lung.
I had zero complications that I'm recalling. Like, yeah, it's
Correct.
not an easy recovery. Don't get me wrong, I'm not downplaying it, but I don't think I had any complications.
Right.
I'm wondering
And that's what I'm
how,
saying. Even the worst numbers that I give, Ashley, it's
yeah,
still only, I mean, but to surge, this is high, right? Because we're
yeah.
used to like, oh, nobody can have a complication, right? But it's 20%. There's still an
Mhm.
80% chance that everything is going to go great.
It's a pretty good odds. And there's
It's great.
complications with everything. There's complications with going on
Correct.
chemo, going on targeted treatment, like staying off treatment, radiation, like, and that's a question that is asked to me often. Someone has the opportunity, they've been given permission to move forward with radiation and with a lung removal. So can you talk about the pros and cons when someone is weighing out this option?
Kind of like we talked about the surgery options are always going to have technically a higher complication rate because we're cutting into something, we're taking something out, whether it's partial lung or a little bit of lung. So the infection rates, the general anesthesia, everything is going to be higher for complication rate for surgery.
Hmm.
So versus radiation. However, the benefits again could be that you're actually removing everything,
Yeah.
right? You're removing everything that you see and physically taking out. Radiation doesn't, it just
Hmm.
zaps it, but it stays there, right? You don't know kind of if what's dead and what's not when you're looking at it on follow-up film. Surgery, you take everything out and then you know it's out.
Yeah.
Surgery, the other benefit is again that you, besides taking everything out, you also stage with lymph nodes. And so you kind of, and the rest, and you can see around what's going on and what is actually microscopically involved,
Hmm.
right? So those are the benefits, but the risks are that you have pain afterwards, that it's a recovery, that you may be in the ICU giving on, depending on what type of surgery you had versus radiation. I think, the thing is that you have a lower complication rate. And that's kind of been shown. But the question is it as effective? We know anecdotally that it is effective, for certain things when you look at versus surgery, just as effective over the 1 year period, the 3 year period, things like that. The question that a lot of people don't debate on is what about longer term?
Hmm.
So a lot of us extrapolate data from the earlier stage disease that surgery is better longer term if you can tolerate it. And that's been shown.
Hmm.
But for stage 4, the question is like, well, you have stage 4 disease, you as the patient have stage 4 disease. Should we be thinking about the 5 year survival if it's already stage 4 disease? So then should we just be going to radiation? And it just depends on what people's thoughts are. But I
Yeah,
think the bottom line that we want to know for the listeners, and for everybody, is that they should also discuss with the radiation doctor and the surgeon when it comes to stage 4. And that's kind of usually what I recommend. And then they can get those kind of pros and cons from the radiation doctor and not just the surgeon.
exactly. And I have met quite a few people with stage 4 lung cancer. Some not having biomarkers that are 10, 15, 20 years out. I just talked to someone who had a pneumonectomy 10 years ago. Um, and it moved to her other lung. She went on a clinical trial and is now cured. So, I mean, we don't know ultimately. None of us have this a crystal ball like foreseeing the future.
Correct. And that's what I mean. The thinking, and the naiveness, I don't want to call it naive. I don't know how you word it, but the thinking is that, well, stage four disease, there is no such thing as 5 year survival or anything. Well,
Yeah.
that's absolutely not true,
Mhm.
regardless of biomarkers, but obviously with biomarkers too, but with or without, that is not true anymore. And so I do think that you can't think of it like, well, don't even think about surgery because you're not going to be alive in a year or two or three. That is old thinking. But unfortunately, that's how people still think to this day,
Yeah.
despite the promising data, despite these
Mhm.
patients that are living longer. I think, people are still caught up in well, the data shows, overwhelming data shows this, and the chances are high that it's going to be this. But if that's your family member, if that's your friend or whatever, are you willing to say, well, that's the data, and so I'll just go with that, and it's too bad. We're not going to try.
Yeah.
And so to me, I'm more on the side of let's try,
Mhm.
understanding that yes, there are risks, but if the patient understands that, I have no problem with that. Whereas I do think other surgeons and other people do have a problem with that because classically they're not believers because it's stage four, and two, they don't want the patient to to have a complication or to risk that for stage four disease. But I'm like, that's up to the patient and
Yeah.
that's up to the surgeon. You shouldn't put that dogma on everybody.
Mhm.
Certainly, you as a surgeon could not necessarily want to do that, and that's fine.
Yeah.
But if another surgeon wants to do that, and they have good results or whatever, or I think it's okay for that
Yeah.
in a way.
Yeah, and a lot of us are young living with lung cancer. And I think regardless of the treatment we're on, our side effects and symptoms are different. I mean, like the cancer presents differently in us, and and I don't know. I think that's something that should be considered and factored in when people have the option of a lung removal. Because unfortunately the data is outdated and I don't think it represents us as young,
100%.